going the extra mile winners for the spring. And first up is the individual winner, and that's Kerry Lane. I can't see Kerry on the gallery at the moment, but Kerry was awarded the Going the Extra Mile Award individual award for her work as a ward clerk in the intensive care unit, for being, according to the nomination, an unwavering source of support, calm, and positivity during an extremely busy period for the intensive care unit. Kerry was nominated by colleagues who described her as the backbone of the unit. They praised her tireless support for all members of the multidisciplinary team, highlighting her ability to bring order, reassurance, and even humour during the most demanding shifts. One nominator said, "She always offers assistance to any members of the ICU team and often goes out of her way, above and beyond her job role." Another added, "Kerry is way more than ITU's ward clerk. She is everyone's listening ear, a kind soul that looks out for the patients and her team." She was commended for her compassion, emotional intelligence, and her talent for easing stress with warmth and efficiency. Kerry exemplifies the trust values, the nominator wrote, and truly is one in a million. Big round of applause, Kerry Lane. Thank you very, very much for everything you do and the atmosphere you create amongst your team. We all as individuals decide our mood every day. Everyone has problems in one's life. Often they're not shared with others, but choosing your mood every morning and the way you approach your work is disproportionately important to creating a great atmosphere. So well done, Kerry. Next, a team winner, and that's the Helen Clark suite. And I think we've got some of the team with us today. So lovely to see you. And the nominator wrote that this was for their recognition for delivering an outstanding patient experience from start to finish. The nominator, attending a fast track appointment, described themselves feeling anxious, but said the staff made her feel at ease immediately. From the receptionist to the doctor, nurses and radiographer, the team were consistently kind, informative and professional. The nominator praised the entire team for creating a welcoming environment and providing compassionate, efficient care that reflected all of the trust's values. The nominator said, "Hospitals can sometimes feel dehumanising, but this absolutely wasn't the case here. I left not only having received the care I needed, but feeling seen and valued." Big round of applause, Helen Clark Suite team. Thank you very much and congratulations. A couple of other call outs. This is Volunteers Week, and we have over 650 volunteers who have given over 30,000 hours of their own time over the last year. We've had 161 new volunteers, and they've made over 6,500 calls and have done absolutely fantastic work in moving forward the trust as it continues to go through various changes. And the great thing about volunteering, if you're recently retired, and I know there are a number of our governors on the call, but whether you're a governor or a volunteer more generally, is a wonderful way to give back to society. So I would strongly recommend for people who are on the call who are thinking about volunteering to really take that forward. The other people I'd like to have a shout out today is for our ED teams. Our ED department is ferociously busy. And this morning we had a presentation which really brought that into stark relief. And I'd just like for all members of the public who are with us now or watching this on video later, but since 2019 to 2024-25, SWFT has seen a 35% increase in the number of type 1 visitors to our A&E. Now, That's compared to an average for the whole of the NHS of just 6%. So we're up 35%. The whole of the NHS is up just 6%. And the largest hospital close to us, our tertiary, actually their type 1 ED demand was down -4%. So we were up 35%. The NHS in total was up 6%, and our large tertiary partner was down 4%. Our ED departments are working incredibly hard, and occasionally they win a Going the Extra Mile team award, but day in, day out, they do fantastic things, and I want to thank them again publicly. Our doctors, nurses, allied health professionals, porters, everyone does a fantastic job coping with that level of demand. And that level of demand hits us because of our reputation. We see a quite enormous amount of people from outside South Warwickshire, which does make our life more complicated. And we'll be touching on the finances later, but when we're paid on a block contract, so a flat amount of money, but we're seeing that type of increase, it makes the finances even more demanding for SWFT. So again, thank you for everyone who looks after our patients. And it's also worth just remembering that in terms of waiting times at SWFT in our ED department, we are absolutely in the top quartile of the mean time for non-admitted patients at 3.8 hours. And the mean time in ED for admitted patients are just over 6 hours. That puts us in the top 25% on both those measures. So big shout out to the ED team, big shout out to everyone at SWFT. So without further ado, I'll take us back onto the agenda. And I don't think we've had any apologies for absence, have we, Sarah?
No, Russell.
Thank you. Any new declarations of interest? Could you please raise a digital hand for me, please? Oliver, you haven't raised a digital hand, but I think you need to raise a digital hand. Oliver Koffler.
I think I did it last time.
Russell. Apologies, Oliver. I may not have been there, but I'm not sure. Is it this? Okay, but do you want to, just for completeness, Oliver, tell us what you're doing?
Sure. Yeah, no, okay. So I've started a role as a Crown representative, which is working with Department for Health and NHS England and the Cabinet Office to support relationships with strategic suppliers across the UK, well, starting with England. So it's about strategic supply management and hopefully working in a better way across some of those suppliers. I'm looking after 4 suppliers, which are Sandoz, Teva, ISS, and Olympus Keymed.
Okay, super. Thank you, Oliver. Any others? Okay, so the minutes of the meeting held on the 2nd of April, which was our last board meeting here. Any points of accuracy on those? Could you raise a digital hand for me, please? Okay, I can't see any digital hands raised. So on page 12 of our pack, we have the actions, and the first was for Sophie to arrange for board members to visit the elective hub. An email was circulated and invite sent, so thank you, Sophie. The next was for Harkamel to arrange for her and I to visit the security team. That's in progress. We had to cancel that, but we will do that. Also for Harkamel on the next point, to provide the board with patient stories to highlight the delays in pathology services. And that's going to become part of a board workshop session. Since our April board, Coventry and Warwickshire Pathology Services, of which we are the minority shareholder, have decided not to expand the network for pathology services to the whole of the South Midlands. We voted for that. We wanted that to happen, but the largest shareholder didn't want that to happen, which was UHCW. So I am concerned about future pathology services for us. And then in a scheduled for a future meeting, Fiona, to ensure the outcome of specialist palliative care service review be included. When do you think that will actually come back to us, Fiona?
I've asked it to come to clinical governance at the next out of hospital report, which is probably in a 2 months' time. So straight from clinical governance, it will come to board.
Okay, super. Thank you very much. Are there any matters arising that colleagues feel I've missed? Okay, so next up is the board meeting minutes from the 7th of May. Again, I would encourage members of the public to come along to those. They're a different type of board meeting, but hopefully are interesting in a different way. Was there any points of accuracy from colleagues which you'd like us to take forward on those? Please raise a digital hand. Okay, and then the matters arising we will take as read for that board to take forward. So just as it's my opportunity to give chair's remarks, just a couple of things to brief members of the public on. Our Group Chief Executive, Glenn, is a little unwell at the moment. So Glenn, we wish you a speedy recovery. In terms of worries that I have at the moment, apart from the level of ED demand that I touched on earlier, which came out of our discussion at the board workshop, I am also concerned about the oncology support that we are getting for our cancer patients and their families. We have discussed this at a few points as a board, but just to explain with your forbearance for a moment, we provide all of the oncology services, so the chemo, looking after you if you are diagnosed with cancer. And we mainly do that out of Stratford Hospital, but not entirely. But in terms of oncologists and seeing your cancer consultant, that service is provided by UHCW and UHCW consultants. Now, there is a national shortage of oncology consultants at the moment, and UHCW have recently put into segment 1 for cancer services. But my concern is that far too often, and it does vary slightly by tumour site, but far too often, South Warwickshire citizens appear, according to our evidence, to take much longer to be seen by an oncologist than if we lived in a Coventry postcode. So we are taking that forward in our debates with the Integrated Care Board and with UHCW. But it has now reached a level of seriousness where Adam and I will be having discussions about what alternatives there are going forwards for us to ensure that the citizens of South Warwickshire see as quickly as possible the oncologists, because as a cancer survivor myself, I know how worrying it is to get a potential diagnosis of cancer and the importance of quickly seeing your oncologist. So when we get to that point on the integrated performance dashboard, I'm sure Adam and maybe Harkamel will mention it, but for the public's assurance, we are focused on it as a board behind the scenes. So with that sort of introduction, I will go on for items for approval. And I think we only have one, which is a very important one, which is our declaration of going concern. So Kim, over to you.
Yeah, Chair. So just this is the standard declaration of going concern. So I'll take the paper as read, as long as the board are happy to confirm that we still are in the business of providing services, health services to our patients and population.
Okay, so being a going concern is actually quite a fundamental thing. So Kim, this comes with your recommendation. Thank you. Any questions or perspectives on the going concern recommendation from Kim? Robert, as chair of the audit committee, any concerns from you?
No, we took this through the committee, and pleasingly, centrally, they redesigned the definition in public services. So it's far more pragmatic, as Kim says.
Okay, super, thank you. If you're not happy, therefore, to accept the declaration of going concern and to confirm it, can you raise a digital hand for me, please? Duly approved. Thank you very much, Kim. Adam, over to you, therefore, for the Acting Chief Executive's report.
Thank you, Russell. I will draw a few points out of the report, and I want to start with the greater collaboration with George Eliot Hospital. So back in April, the boards of both SWFT and George Eliot approved a move towards greater collaboration between the organisations, and that will take the form of a shared leadership team and shared governance arrangements where appropriate. And we're doing that for a number of reasons. First, to support the sustainability of both organisations. We know there is significant duplication in our corporate services in particular, but also recognising the changing landscape in Warwickshire and our role as a lead provider to ensure we are talking with one voice for all of the residents of Warwickshire. Really providing a sustainable organisation for the future and for our patients. What is the absolute focus of that work is ensuring we maintain local services for the residents of both South Warwickshire and North Warwickshire, and indeed Rugby, where we provide community services. We are talking through the next steps for that plan, and we will share more detail with the boards when we have it. As I say, we expect to finalise those over the next couple of months. We're not at this stage talking about a merger between the organisations, and I think that's a really important point to make. But we are talking about greater collaboration, which will support sustainability and support our patients across Warwickshire. I also want to talk about our EPR system. I've mentioned it here before. We've been working for a number of years now to procure and contract for a new electronic patient record system, and we have contracted with Oracle Health now to supply that system. And that is a great opportunity for us because it means that the 3 acute trusts in Coventry and Warwickshire will be on the same system and able to share information much more effectively in a way I think the public often expects that we already do. An EPR implementation, though, is an incredibly challenging project. It's not just about putting an IT system in place. It's a full-scale transformation of the way we work. It enables different ways of working. EPR implementation projects are always incredibly challenging. There are always issues along the way. And we are doing an awful lot of work to make sure we implement the Oracle Health system in the most effective way. We started work with our clinical teams during May, and that work will ramp up now over the next few months. We expect to implement the system around about October next year, but as I say, it'll be an incredibly challenging programme that will involve everyone in the organisation, but will ultimately provide some really significant benefits in terms of quality, safety, and our own productivity. So we will continue to update the board as that work progresses. Challenging, but I think really exciting for us and for our patients. I also want to point out the Foundation Group Improvement Week, which took place from the 12th of May. It was a really fantastic opportunity for the 4 trusts across the group to come together, share some of the best practice, some of the improvement journeys for specific projects we've done, but also a great opportunity for learning and our staff gaining new skills and experience. It was a really successful week. We've had some fantastic feedback. I know SWFT staff were particularly involved in sharing some of the great work we've done, but I've also heard our staff say how much they learned from the other organisations. I am sure we'll have a similar event next year because it was a fantastic week, as I say. And thank you to our service improvement teams who helped coordinate that week. I also want to talk about the CQC inspection that we had in March. I did mention this briefly in my April report. We had an unannounced inspection of our urgent care and medical wards services back in March, and we received some immediate feedback from that. We received some positive feedback, particularly in terms of improvement work that we've done and innovative initiatives we've done, and certainly in terms of our staff culture. But we also heard a number of concerns from the CQC, and I think we can set those in the context of the increased demand that Russell has already spoken about. That said, they are genuine concerns and we have responded to those. We have put some immediate actions in place, and we've provided more information to the CQC, and we've developed our action plans. We are obviously still in dialogue. We haven't received the final report from the CQC yet, and we will share that further when we do. The report highlights the GEM Awards, which we discussed at the start of the meetings, and also finally, in more from our great teams, we talk about the North Warwickshire community place-based teams. I think it's really important to highlight the services we offer outside of South Warwickshire, because it is a really important part of our service portfolio and our community services. Teams are doing some really great work, particularly with George Eliot in collaborative working. They've also got some really fantastic innovative practice. They were the first community teams to implement our new wound care app and are really seeing the benefits of that. And there's some other great work there that they're doing, detailed in the report, including their consistent improvement in community care indicators. So thank you and well done to that team. It's great to highlight the work they do. As always, the report finishes with a list of some of the formal visits to services that execs and non-execs have done. And I'm happy to take any questions.
Yeah, thank you, Adam. Just on that last point, they're the formal visits. Just for members of the public, there are a lot more informal visits that go on. Any questions or perspectives to Adam? I think just building on what you said, Adam, about the EPR work, all of the board are very aware of the risk around getting this wrong, and therefore the steps we need to ensure that we minimise the risk of things going wrong. It is going to be a big opportunity for us, but also a big risk. So for members of the public to be assured we are all over it like a rash. Any other questions or perspectives to Adam? Otherwise, I'll move us on. Okay, thank you. So we'll move on then to the integrated performance report. And do you want to do the introduction to this, Adam?
Yeah, I'll be brief and let my colleagues do the detail of the report. But just in summary, it was another busy month as detailed in the report. Despite that, we have seen a really sustained improvement in our ED performance, albeit it's not where we want to be. We've mentioned oncology already, and I think it would be great if Bhaskar could give us a bit more detail around that as part of his report. I think it's really important we're clear here at board on the challenges we're facing there. Beyond performance, I think the report details some of the work we're doing with the community integrator and our role as a lead provider for community services. And I just want to highlight this work. So I think it's a really important part of what we're doing, and it really allows us to develop and look at those pathways across community services with our partners, but also looking much more in depth at neighbourhoods. And we've had some fantastic workshops over the last month on the development of integrated neighbourhood teams with partners. There is more in the report, as I say, about that. In terms of staffing indicators, sickness remains an area of concern and an area that we're focused on. Wider recruitment indicators are going well. In terms of finances, we're really, really early in the financial year. We are on track with the plan we set at the start of the year, albeit that plan for the first month of the year was a deficit plan, which we expect. as our CPIP schemes embed and ramp up through the year. That's all I want to say, but I will hand over to my colleagues. Perhaps we could start with Bhaskar on the oncology.
Okay, so over to you, Bhaskar, and then Fiona. Bhaskar.
Thank you. Just to clarify, obviously, oncology is a national issue in terms of workforce challenges, and the oncology weight, we're not alone even within the system, but through a combination of the workforce issue as well as some sickness, which we ended up unfairly getting slightly more lopsidedly getting affected, that the waiting times are impacting more so for our share of patients, while the whole system also struggles just anyway. And within that, there has been some discussions, and this morning, Hakamal and Sophie have met with the system leaders to try and get the commitment, and they've already committed to a stakeholder board, which will enable, because they've already set up a network of leaders from the 3 trusts to try and jointly work together, because the workforce of oncology entirely sits with UHCW, but the challenges are universal, except we ended up getting a slightly more lopsided impact. So there is a commitment from the network that they're setting up a stakeholder board that at pace will look and see what necessary changes that we could make, so that whatever limited capacity there is equitably offered for all patients in our system, as opposed to the current, not a design, but a quirk that we ended up with some patients having to wait as much as 20 weeks after a firm diagnosis of cancer for their first appointment. So this is real, and the impact is telling and increasing. And while we do keep a very close eye on harm review where the delays are extended beyond acceptable levels, the psychological harm is immeasurable, and it's not easy to put a value on what damage that is. So I think there is universal agreement, and we are ramping up our efforts to work with the system, with all the existing stakeholders to try and address this. But this is one of those that does genuinely worry all our patients actually with cancer. If I stop there and hand over to Fiona for the patient indicators.
So just before we move off cancer, any questions or perspectives from colleagues on what we've heard from Bhaskar? The only thing I would encourage Adam, Bhaskar and colleagues is, for the sake of the citizens of South Warwickshire, we need to ensure we have options in this. We can't allow our citizens to become victims of a particular provider's challenges. We have to find solutions where other solutions might be available. So over the next few months, it would be good to understand what those other options might look like. Over to you, Fiona, then.
Yeah, thank you, Chair. So I wanted to start with just giving assurance to our public and our board around clinical governance and how we monitor quality and safety in light of what Adam has reflected in his report around CQC and the concerns that they found. So I am confident that we have good governance in this organisation. We review incidents and complaints with detail and robust processes through clinical governance to look at trends and assure ourselves that improvement action is being taken. We, as part of this integrated dashboard, we see it at board each month. We see the incidents again and complaints, and this is our opportunity at board level to review it. With that in mind, I'm conscious that there are some gaps in our integrated dashboard today, and we'll pick. I can assure the public that I've sought clarification on those gaps, and they will be filled next month. So just in terms of the gaps, just to make sure that the public absolutely know that we're looking at the detail. So the cleaning standards that are not reflected in the integrated dashboard are within target. They're at 98% and have been for the last within target for the last 6 months. VTE is reflected in Q3 data and integrated dashboard. We've got Q4, and that is improving, and we are now monitoring VTE on a monthly basis. So again, that will be reflected in the dashboard going forward. WHO checklist as well. is at 99% this month. And the falls with harm is in terms of year-to-date position is the lowest it has been at 1.02%. So again, I can assure you that the outcome of patient care is still in a good position. The areas that are challenging and the focus for the coming months is the trend that we're seeing related to incidents and complaints. Both of those have gone up. The incidents I understand better. So we've changed, as the board will remember, we've changed from a Datex national system to InPhase alternative supplier, and InPhase inputting interface for staff is slightly different in that if they put a incident that is a near miss, it doesn't default to a no harm position. It still allows you to choose whether there's low harm or moderate, and that is showing in some of their near misses actually coming through as harm and needing to be corrected. It also has a weighting that is slightly different in display, and so people aren't choosing the first one, which is no harm, but actually the middle one, which is low or medium harm. And so there's some human psychology coming through in terms of how they're reporting it, which is reflected in some of our data. That's not to say I'm being complacent in any way, and my team is scrutinising that harm and reviewing it and learning any lessons from any harm that is going on, as in the same way as they always have done. Complaints going up is a concern, and again, the commentary I have on that at the moment is our patient experience team is in a fragile position at the moment. There is only 4 of them, and we've got some gaps in that. So we've asked for some mutual aid from partners across Coventry and Warwickshire in terms of just helping us to have manpower to manage complaints and PALs, but we need to review that resource that we put to that, because that team is very important to ensure the oversight of complaints and PALs, and the learning and the diligence around responding to the public on that is really important, and it is a fragile service at the moment. That's all I wanted to say. Thank you.
Thank you, Fiona. Just on the complaints team, could you pass on the board's thanks, because they have a tough job day in, day out, always hearing where things have gone wrong. So can you thank them, particularly as they're short-staffed? Just on the governance point that you made, Fiona, David Spraggett as chair of clinical governance, and most members of the public may know, but you're an extremely experienced GP, been chair of South Warwickshire CCG in the past, done a variety of different things with the Royal Colleges and with NICE. So at its simplest, you know what you're talking about. How do you feel about the governance arrangements at SWFT?
I think they're very sound, personally. I mean, I think going on to the thing that Fiona's talked about with the incidents, that's being dealt with very effectively now, and I think it should anything actually be demonstrated that is less than ideal, I'm confident we'll deal with it appropriately and improve things. So I don't have any great concerns about the governance on this.
Thank you, David. Questions and perspectives to Fiona or Bhaskar? I can't see any digital hands raised, so therefore I'll move on to Harkamel. So Harkamel, how are you feeling about the core operation, the core machine, so to speak?
Well, I feel like I say every time how busy we are, but we are still quite busy. And against that backdrop, I'm really proud of managing to sustain a small improvement in our A&E performance. It is under where we need to be, but we are still experiencing quite high levels of demand. And it's really interesting because in the report I framed it as our attendances have fallen, but that's only compared to like previous months. If you compare us to where we were in 2019, it still represents a significant increase. And the reason that I compare it to 2019 is because we still have the same bed base and the same infrastructure. But it is important to point out that we are making small improvements month on month. Ambulance handover delays were one of our lowest ever, and we do pretty well on that anyway. But I was really pleased that we have managed to continue to improve against that. We did see quite a few issues with stranded patients and infection control measures, meaning that we had to close quite a few of our beds, and that's quite late in the year comparatively. Like, we didn't see that same pattern last year seasonally, and so that just added extra pressure on managing some flow. From a diagnostic position, our waiting list is finally starting to shrink again, which is really important because we've really struggled to hit the target in the way that we want to. We actually achieved 91.9% for April. Referral to treatment increased, and we are still making quite good gains on our 18-week position. We've done a lot of data cleansing, so taking off pathways where they should have been closed, and a lot more validation, which will affect our performance, but it is the right thing to do to make sure that we are looking at the right data. And I have noted in the report that we are still struggling with oral surgery and orthodontics, but I just wanted to assure the board that we are making really important improvements in that area, and especially in orthodontics. So within a few months, I'll be able to say that we've cleared most of our long waiters. That said, orthodontics is still an area of worry. There hasn't actually been very much fundamental change in the way that pathway is managed out in the community. So the onus will be on us to make sure that we don't just open ourselves up to sort of fail again, and we manage the demand, the most urgent demand, as effectively as possible. So I'll come on to cancer. I have in the report, I've detailed all of our compliance against the standards. And so these are when patients come from their GP into our hospital with a suspected cancer. And so the 28 days after diagnosis talks about how quickly we need to tell patients they've got cancer. All patients need to have started a definitive treatment by 31 days, and that all needs to be finished. Well, that's if they have surgery or go straight to chemotherapy, and the definitive treatment has to be within 62 days. And we are really struggling with that. We are seeing significant increases in our demand along that pathway, so those patients coming from their GP and coming through to our services, and that's reflected a little bit in the narrative. I just wanted to draw back then to the conversation about oncology. So once the patients have been through the cancer pathway, they might have surgery and then oncology or chemotherapy or radiotherapy, or they might go straight to oncology services and go for chemo or radiotherapy. Patients already have to go to UHW for their radiotherapy because that's where the machine is. But the bit where the decision happens is that first outpatient appointment with an oncologist. So we have been seeing these patients. So the surgeons where the patients get referred to have ownership of these patients. We are cited to them. So I just wanted to provide that assurance that when we're talking about some of those long waits, it's because we know exactly who these people are. So they might have gone through their first part of their pathway. They've definitely got cancer, they've been told, and we're managing that with them. And it's that delay then afterwards for those patients who need to access oncology services. And Bhaskar's already sort of talked through the wider work that's sort of going on within the system, and then we'll continue to update. From a cancer perspective, there is a lot of work that's already ongoing, and one of the tumour sites that we're most worried about is urology. So Bhaskar, Fiona and I are going to meet with the team just to understand their pathway and see if there aren't any further improvements we can make along the start of the pathway. But I mentioned urology because that is currently where our longest wait is for an oncology appointment. So it's just to provide assurance that we're looking at the whole part of that pathway. And then finally, I did put some slides in, put a slide in around the community integrated programme because I've not updated on that in a while. And it's just to update that a mobilisation project group was initiated back in February and is progressing well. We are currently just mapping through what some of those key performance indicators are going to be and finalising what the workshop's going to look like in July. But all of that detailed in my report.
Fantastic, thank you, Harkamel. And thanks for the enormous efforts you and your team put into delivering the patient care we're able to deliver. Any questions or perspectives to Harkamel? Harkamel, can you make sure that at every board for the next few months, I know we talk about cancer anyway, but it gets a high profile in your report over the next few months as we seek to improve the performance. And we'll move on then to workforce. Elva, lovely to see you. Over to you.
Thank you. So yeah, as Adam has referenced earlier, we still have a significant focus on reducing sickness absence across the trust. We have seen a reduction this month, and as you can see within the pack, there has been a significant reduction since January this year, where we were over 6% and we're now at 5%. So steady progress in reducing that. Now, in addition, we have we do really well consistently with recruitment. Our time to hire remains low, and we average at 2 days. So that's with getting somebody interviewed and sending out an unconditional offer letter, which then allows them to hand in their notice and start with us as soon as possible. We have had that risk-based approach in place for quite some time now, and that is still going really well. Now, in addition, we have also had a decrease in our turnover, and it has remained below target for over 12 consecutive months now and beyond. So that's really positive. And lastly, it's just the focus really on appraisals and mandatory training. So following the CQC, we've really kind of upped our focus around the appraisal compliance, ensuring we have oversight of all staff groups. And there has been a significant improvement within the compliance since the end of April to the beginning of May. So the same, we are still below target. So there is still a push to be done on the appraisals, which will continue. But with mandatory training, we are above target as a trust, and have I've included all the divisional breakdowns, which are also all above target within the pack.
Thank you, Elva. Questions or perspectives to Elva? Elva, it's great that we're down to sort of 5% sickness level, but that's still 1 day in 20.
Yeah.
Keep the maths easy. That means 12 days sick a year on average for each member of staff. So that's a big number. As Glenn, bless him, who's had to have a week off, often says, in his 35 years of being with the NHS, he'd only had 2 days off sick in 35 years until the last week. But I particularly worry about our occupational health services, which you reference. And I asked Natalie Cook over at George Eliot yesterday at the George Eliot board, because I know UHCW are worried, and it's their service on occupational health. I'd like us to have options, George Eliot and SWFT to have options. We've been talking about the problems of Occy Health and the UHCW service for at least the last year, but bluntly, nothing has changed. So your challenge, in a true Mission Impossible type way, Elva, is with Natalie's to come up with some options for us to, as a board, to be able to consider on Occy Health. Because if, as Einstein famously said, if you carry on doing the same thing and expect a different result, then you're being silly, and we're not silly. Can I leave that with you?
Yeah, no problem. And just to assure you, we have that already underway, so we should be able to give you something quite soon.
Okay, look forward to it, Elva. Thank you very much. Colleagues, happy to move on to the money. So Kim, as Adam has mentioned, we made a small loss, but that was planned. How are you feeling about the money?
Thank you, Chair. So, yeah, we've made a loss in month 1, but it is month 1, and we are expected to improve that trajectory as we progress with our cost improvement programme towards the end of the year, to hopefully deliver the plan, which is a £2.3 million surplus. It is a challenge, particularly in light of the operational pressures that Harker Miles has already alluded to. So just to give a bit of context for the people, for the members of the public, you know, in order to keep our patients safe, and with the extra demand that we're seeing, we obviously have to put in the appropriate staffing levels to ensure that our bed capacity can cope with the level of demand, and also to make sure that we've got the right staffing in our ED department. All of that comes off with a cost. Sometimes it's not a planned cost, and therefore it comes at a premium cost, which is more expensive. So that's the challenge for us, and we do not get paid any more for seeing any more patients for in those areas, which is the challenge for us. So that is a risk to the organisation in terms of delivering its financial plan, and the other is around our cost improvement plan. So we did set a plan with the expectation of delivering a £23 million savings programme for the rest of the year. So far, we've identified about £18.7 million of schemes against that £23 million. But in the forecast, there's only about £10 million factored in. So the work needs to happen now as soon as possible to ensure that we turn those identified schemes into deliverable schemes, and make sure that we support the organisation to ensure that we can deliver those, but also to close the gap between those that have been identified versus the target as well, to ensure that we hit our financial plan, notwithstanding the operational pressures obviously driving some spend that is, you know, potentially out of our control. I've also mentioned in the report some of the risks as well that we may be aware of. There's talk about potential industrial action, and we obviously don't know what that means for us. And there's also been announced the offer of pay awards, which has been higher than the assumptions that we had factored into the initial planning around. Now, clearly, that's a national issue that hopefully the money is found nationally to fund the pay award. But our experience from last year shows us that there is a risk attached to that as well. So I think it's pertinent to bring the board's attention to that as a potential risk to our plan moving forward. Bank and agency, we've set some ambitious targets as requested really nationally to ensure that we reduce our temporary labour spend. We've set a target to reduce our agency by 40%, which is about £4 million. And actually we're doing quite well on that, which is really great. And thank you for everybody's hard work in ensuring that we're on track to deliver that. Bank spend reduction is proving more challenging. The expectation is to reduce by 15%, which is about £9 million. But we have had some challenges already in month one, and that can be directly associated with the additional pressures that we're feeling operationally. So those are the key things that I just wanted to highlight to the board today.
Thank you, Kim. Questions and perspectives to Kim? Look forward to us closing that 5 million CPIP gap, which is still unidentified, Kim. So members of the public, the rhythm of meetings on finance and performance is through a finance and performance monthly meeting with each of the divisions, and Kim runs those. So that's how all of the board gain assurance that work on those CPIPs is developing and being delivered. Team, we're running a few minutes behind because we've been, I think, very appropriately talking about some of the challenges we face. But if I could ask colleagues now to try and pick up the pace a bit as we run through a whole series of reports. First up is quarterly safe staffing. Fiona?
Yeah, so briefly, I can assure the board that we have good oversight and governance around staffing. Again, as this is a monthly report, a quarterly report broken down by divisions. It explains where the risks are, but how we're managing them, and the challenges in month, which we've already reflected on, is the continued sickness. However, again, we've already said the vacancy position is in a strong position. With that financial picture that Kim's just explained, it's going to be really even more important to do quality impact assessments on any decision around staffing reductions, or and my team will do that within the divisional conversations and F&P. So I'm happy that we are making the right decisions in a financial context. Thank you.
Thank you very much. Fiona, any questions to Fiona on the quarterly safe staffing report? Okay, we'll move on then to the perinatal quarterly report. Lorraine, over to you.
Thank you, Chair. And I'm going to take the report as read. This is Q4 data. So as we've discussed in previous boards, our birth rate remains high, and the service has obviously been undertaking a deep dive into our maternity and neonatal services, and to look at our future planning and long-term strategy. We have now had the opportunity to look at our birth for 2024-25 and to say that we hit 3,413, which is the highest number recorded, and that's a 3.2% increase on last year's birth rate, and around 1/3 of these births were to women birthing outside of, where their GPs are outside of South Warwickshire. So we know that our trajectory for the next financial year is going to take us past 3,500, which is more than we're able to cope with. So we are working with the exec team to look at options to how we can make those births more safe, provide areas looking at making sure that we're capping births within that area, but with support and temporary options and support from the ICB and the regional team to look at longer term strategies around capacity across the region. We also I've been working with our theatre team in the main theatres to take over our theatre management, because we know that our theatre refurbishment is still on hold, and we're doing some collaborative work to make sure that those theatre opportunities are planned efficiently with our theatres, and they will take over that management going forward. So that's really important progress. In Q4, there were 3 cases reviewed under the perinatal mortality review process. All cases have been reviewed, and bereavement support for those women and their families involved and the staff, and learning shared from any of those cases. Those are included in there. Our rolling stillbirth rate is 2.9 per 1,000 births, and that's still below the national average of 3.29. Our avoiding term admissions to special care baby unit rate was 4.6%, and that's again still below the national target of 6%. You will see that our Saving Babies Life compliance in Q4 was at 99%. That 1% is going to be really difficult to achieve, and we know that they are bringing out a new edition, so that is we're waiting to see what changes that will bring. You will see that our smoking data has fully met compliance for the whole quarter, and we've hit 100% compliance in our referrals to our smoking and stopping smoking and pregnancy service, and we've brought that service in-house to SWFT now, so that's improving our target rates. Our vacancy rate is below 3%, and we have recruitment in progress for our newly qualified midwives for September, noting that we've only got about 5 vacancies. We had 150 applicants, so it's really pleasing to see that our students want to come and work here, but it's concerning that there isn't job opportunities for all our students that we're training regionally at the moment, but we will do our best to recruit where we can. Our training compliance is above all of the trust targets. Our focus, as discussed, is around our sickness, and we know that some of our sickness rates are driven by the capacity issues and concerns that we have got within maternity at present, but we're working really hard with HR and health and wellbeing to ensure that we are ensuring staff are attending work. And finally, our CNST compliance for Year 6, it was embargoed, but I'm pleased to say that we did achieve full compliance for the 2nd year running, and Year 7 has now been released, so happy to take any questions.
Thank you very much, Lorraine. Questions or perspectives, Adam?
Thank you. I just want to support what Lorraine said and give some assurance to members of the public. Thank you, firstly, Lorraine, for the work you and your teams are doing in maternity. Fantastic work, as always. But that fantastic work has led to the real increase in demand on your services that we've seen, and that poses a number of challenges for us, as you say. Not just in terms of staffing, but in terms of the physical space we have available in the maternity services for expectant mums and their babies. I just want to provide some assurance to members of the public that our prioritisation is on the safety of the service, and that means we are taking decisions and will be taking decisions based on keeping our maternity services safe and assuring that women can give birth to their their babies who are local to us in South Warwickshire. We are actively working on our plans and our maternity strategy, as you say. But again, the safety of our services and the ability for expectant mums in South Warwickshire to give birth here remains our priority.
Thanks, Adam. Any other questions or perspectives? Fiona, just remind us, if you would, please, those maternity services around us that have closed in the last 5 years or so.
Closed or changed from a high risk to a low risk. So Solihull birthing unit closed, Horton closed or changed, didn't it, Lorraine? Good Hope in Birmingham has closed 2 elective C-sections. There's another one, Lorraine, and I can't think off the top of my head. Help me here.
I just wanted to
Those are the
illustrate.
main ones.
Redditch.
Redditch.
I just wanted to illustrate to members of the public that a number of maternity units that used to be available for expectant mums are no longer available, particularly if they want to have a C-section. So that for me has been a bit of a nonsense when the population of the UK is growing so strongly. The other nonsense is one Lorraine sort of mentioned but passed over. For me, it's somewhat odd when the NHS in litigation spends something like £1.5 billion every year on maternity related cases, that it can't fund places for all of these wonderful midwives who are coming to the end of their training. I think you said, Lorraine, we've got 3 vacancies and 150 applicants.
Yeah.
Now that's partly due to the fact people want to work at SWFT, but it also reflects the fact that this year there are more midwives available than there are posts. And that is a really odd thing to be happening. I would really encourage people at the centre to spend more money on midwives and therefore less money on litigation, rather than having less midwives and being forced to spend money on litigation. For me, it's the wrong way round. Robert, then we'll move on.
Well, it was just a quick one, because we often describe a number of our funding arrangements that they're fixed, they have a ceiling, they don't change when activity varies. I just want to check with Kim, is that the case with maternity, or do we see a kind of reconciliation each year when we take count of the number of births that we've had in the trust?
You're ready for me to come in? So no, so the way it works is that for patients that come from Birmingham and Solihull area, we do get paid for the numbers of births that come from those areas. In terms of any other areas, they're a part of a fixed block allocation that would have been set a few years ago. And what happens then is that we might see, those values adjusted by a level of growth that is deemed to have been passed down nationally, but not necessarily reflective of our actual growth, which is part of the problem that we're facing.
And as Fiona's popped into the chat box, we do have enough midwives for the number and acuity of women and babies that we see. But if we were paid on a volume basis, we'd be in a much stronger financial position. Lorraine, I've got a lot of ground to cover, so unless...
Very quick. It was just to come back on Robert's point to say that block contract hasn't been reviewed since 2019. So we know that our acuity has gone through the roof, but actually the payments haven't gone in line.
Yeah, and therefore, at its simplest, maternity is a loss maker for us to think about it in those terms. But as NED safety champions, David Spraggett and myself are very assured and delighted at the work that the team have done. And that CNST success is demonstrative of that. Thank you very much, Lorraine, and please pass on our best wishes to the team. And to those mums and dads who have just had healthy babies. What a blessing a healthy baby is. Patient experience annual report, Fiona.
Thank you. So so this is a summary of this is annual report. So this is figures and data that you've had before. We've had a good year. We remain relatively low, depending compared to our demand on formal complaints. The patients and their families still use PALS as an inquiry, rapid response for any concern or question that they've got, and that's reflected in the figures. And we can demonstrate, we learn from concerns and complaints raised. We've got a good bereavement service, translation service, volunteer service. We benchmark well with our national patient surveys that are processed through CQC. Our focus for next year is to keep a close eye on those complaints. We've had a little bit of an uptick, and just want to understand that, to bolster our patient experience team, as I've already reflected on earlier, and to try and get our friends and family test completion rate higher. So they're our targets for next year. Thank you.
Thank you very much, Fiona. Any questions from colleagues on the patient experience annual report? Okay, lots of day in, day out work goes to make that annual report what it is. Thank you, Fiona. We'll move on to the Improvement Board quarterly update. Adam, anything you wanted to pull out of this paper?
I'll take the majority of the report as read, just to say we had a really significant amount of improvement work going on, led by our staff. I think improvement is part of our culture, and it's what people do every day. The report highlights some specific work in our haematology and pain services, and also some of the work that has gone on to support digital care. Over the last year, our patients tell us we're sending them too much paper, and we need to provide them options to receive things digitally. So we have done that and are doing that, while not removing the paper from those who want or expect it. In terms of our improvement methodology, we continue to use the CUSA framework, which was an NHS developed framework, and our staff tell us it's a great tool for supporting the work that they do. And of course, we use Improvement Board to review the impact of business cases we've approved as a board or at management board, and there's some details in there. Happy to take any questions.
Thank you, Adam. Any questions to Adam on the Improvement Board work? Really important background mechanism for us to drive change. Thank you, Adam. Then we're on to the 6-monthly update on trust performance against national guidelines on learning from deaths. What would you care to pull out here for us, Bhaskar, please?
Thank you. I'll take the report as read, and I would want to assure the board that our mortality figures remain firmly under control and on a downward trajectory overall. And the Mortality Surveillance Committee keeps a close eye and reports to the Clinical Governance Committee on themed learnings that we can pick from the RAMI figures, which also continues to be in control overall. And you will see that the sepsis and pneumonia and AKI RAMIs have been signaling a bit of an adverse concern, but both sepsis and pneumonia are firmly coming back on track in terms of direction of travel. AKI is something we have invested a bit more deep dive into it. And going back to the DATIX, to the in-phase upgrade, we're also imminently moving to the mortality module within in-phase, which should provide us even more clarity and deep dive and smoke signals earlier in the course. But overall, I think we should be assured that we're providing, despite the pressures at the front and the volume that you've talked about earlier, Chair, that we're providing a fairly safe and robust service, evidenced by the mortality figures.
Thank you very much, Bhaskar. Bhaskar, I really like the way the report is written. You know, I love reports that says things like what worries you and why. So nicely structured report for people like me who sort of aren't medics. Questions or perspectives to Bhaskar? Thank you, Bhaskar, and thank you for your hard work on a whole variety of things. We'll move on then to the Capital Programme Q4 report. Anyone who's visited our sites or the Adam Badger or Linnington will see the enormous amount of work that's been going on here. Sophie, anything you'd particularly like to pull out of the report?
Just to say it's been an incredible year from a capital perspective. I think to end the year with 154k underspend on a £40 million programme is impressive. We've achieved that by everyone pulling together. So not only our capital and estates teams, but our clinical and operational teams that have supported us to do it, but also finance around how we've been agile with our thinking and procurement. I guess the thing I would draw out is we're going to need that again for the year that's coming. So one of the things that's really enabled us to focus on delivery is the ability to be agile in our decision making as a board and a management board. And the year that's ahead of us is already looking to be a roller coaster in terms of the funding mechanisms and how the money's coming down to us. But it's just really a huge thanks. It was an incredible year, so it's good to have it here to recognise that.
And, you know, huge thanks to you, Sophie. I know you're suffering with a cold and hay fever today, but huge thanks to you for your leadership over all of this. I mean, it's been a quite phenomenally busy year. Under your leadership, the team have done phenomenally well. Thank you. Any questions to Fiona on the capital programme update? Okay, so I think we're then on to the 7-day working annual compliance report. Back with you, Bhaskar.
Thank you. I take the paper as read again, and you should be assured, the board, that we're providing a fairly robust 7-day cover that's going to go up even more as we expand the frailty offer to Saturday and Sunday, hopefully soon. And you will see that we're working hard at pulling back on the length of stay, be it on weekday admission versus weekend admission, but we still have a gap, so there is room to improve further. But I think overall, you should be assured as a board that we're providing evidenced safe service across the week, regardless of weekday versus weekend. I'll take any questions. Thank you.
Thank you, Bhaskar. Any questions or perspectives on the 7-day working report? Okie dokie. So Freedom to Speak Up Guardians report. Sue Pike isn't with us today, but Elva's kindly taken the report on her behalf. So Elva, what would you care to pull out of the FTSE report?
So thank you. Yes, so this is a quarterly report. So this covers the period from the 1st of February to the 30th of April. The team are continuing to support staff events and roadshows, as well as promoting Speak Up across the trust. They work very closely with the staff retention group, our EDI lead, and our wellbeing lead to make good headway in promotion of Freedom to Speak Up. And within the period that we're referring to, there's been 48 Speak Up new contacts, and those are broken down within the report if you want to have a look in more detail. But top themes are around attitudes and behaviours, incivility, bullying and harassment. And although looking at Freedom to Speak Up, you could look at it and think, well, that's a lot of Speak Up cases, but that's a really good thing that people are empowered to speak up and that we are hearing those concerns and actually being able to intervene and to make change in the areas that needs to be done. I will leave it there. Happy to take any questions. The only other ask within the report is that all board members to complete the 3 modules of Speak Up, Listen Up and Follow Up training. Thank you.
Thank you, Elva. Down, Shep. Any questions or perspectives to Elva on the FTSE report in Sue's absence? Adam.
I just want to plug the work of the Anti-Discrimination Help Desk, which has been a really fantastic initiative that we have implemented over the last year. We know, I mean, despite our really positive staff survey results, we know, sadly, that there are some from minority groups in particular that have a different experience of working in the trust, and a real focus of our work is ensuring we are supporting those individuals. And I think the Anti-Discrimination Help Desk, and indeed the wider work of Freedom to Speak Up, is a really important part of managing that.
Yeah, we had a similar discussion, didn't we, Adam, in the George Eliot Ball Jesty, and I made it clear that there is absolutely no place for behaviour which is misogynistic, sexist, racist, takes a particular religion and criticises it. When one comes to work in the NHS, one should come with kindness, caring, consideration and respect for every single member of staff and for patients. And equally from patients, we expect you to hold those same values when you relate to our staff. Fiona?
It just occurred to me, Alva, and I should know this possibly, but how do we benchmark from freedom to speak up against other organisations? And is that data even available? Just thinking about a kind of a leadership, well-led sort of assessment that we might, we will be undertaking next month.
I think we can, Sue works across George Eliot and ourselves, so that's something which I think she could be able to pull together quite quickly across the group. I'm not sure who the leads are, but I'm sure Sue will know.
Yeah, no, I do know. Fiona, can we take that away, minute it please, Sarah, and ensure that Sue produces something? It would be great to get stuff outside the foundation group. Within the foundation group, we definitely have it, but your point, yeah, Fiona, I think that would be good. I think in summary, we believe our FTSE speak up rates are higher than the average, which is taken to be a lead indicator of open culture. Colleagues, happy to move on? Okay, super, thank you. The report from the Council of Governors meeting held on the 8th of May, I'll take as read, but would like to thank all governors, particularly new governors. We've seen some friends returning as new governors as well, thinking particularly of Michael Cox. But thank you for taking up the mantra of the responsibility of being a governor. It's not a particularly easy role, but it's appreciated. And a whole variety of different areas looked at as indicated in the report. Any questions on that report? Please raise a digital hand. Okay, so I'll move on then to the Digital Health Board and EPR governance report. As we said earlier, a real area of scrutiny. Adam, but anything you'd like to pull out of this report in particular?
I will take as read. Clearly, the primary focus has been on the electronic patient records programme, and certainly that will continue. There is other work going on, though, notably the implementation of a new endoscopy system, which is nearing completion, and a significant amount of work on innovative practice, innovative developments, which we're working with partners across the system on. I think one of the disappointing areas that we've had is slow progress on the voice recognition system that we want to implement. We believe we are in a place now where we will be implementing that over the next few months, but it has been extremely slow and very disappointing given the productivity benefits that come with it.
Thank you, Adam. I agree with that. I think particularly Wye Valley are miles ahead of us on this, and we shouldn't have allowed that to happen. Questions and perspectives on Adam's report? Adam, I'd like to have a cup of tea and a ginger nut biscuit and talk about the digital hub with you. For me, we have so far lost momentum around the digital hub generally. And, you know, the future is technology in healthcare. The future is far more blood testing. The future is AI. And I just really want to make sure that we are getting some of our best medical and academic brains on that whole opportunity. And at the moment, we feel to be nowhere. We'll come back to it, Adam. I'll buy the ginger nuts. Colleagues, happy to move on? Then we've got the Audit Committee report for the 9th of April, including the self-assessment. Robert, anything you'd particularly like to emphasise on this?
Well, I hope you can see it was a very busy agenda, and we took 3 very important papers on the accounting treatment of certain matters listed there. Importantly, we took external advice on that, and so the audit committee scrutinized that advice and the approach, so we're content with that, and the auditors will now turn their attention to it. As you say, other than that, we looked at a number of things, including our own self-assessment review. We're pretty clear about where we receive our assurance and our responsibilities. There's some areas that we can improve upon. And sorry, the first thing I should have said, and this is a final point, Thank you to Harkamel for coming along and speaking to the follow-up report on the aseptic suite. There's just a few outstanding recommendations there, and so we'll keep that on our radar for now.
Thank you very much, Robin. Thank you for the leadership of the Audit Committee. Any questions or perspectives on Robert's report? Thank you. So we'll move on then to the Clinical Governance Committee reports from April and May. David, anything you'd like to pull out here?
The increased number of incidents with harm Fiona's already dealt with, I think, earlier on. But the only thing I really want to point out is that there has also been some benchmarking done regarding our harms rates nationally, and it seems we are well below the national average for that. So although our trend appears to be adverse at the moment, we're still well below the national trend.
Okay, thank you very much, David. Any questions or perspectives to David? David, thank you very much for your work on that and lots of other areas that I know you helped the team on behind the scenes. It's appreciated. Okay, team, we'll move on then to our strategic direction points. And the first up is the year-end position on the annual trust and FG objectives. Adam, what would you care to pull out of this mainly green report?
Yes, thank you. And that was the first thing I wanted to note. So there's a lot of detail here, and I certainly won't go through it all, but I think it's reassuring that the vast majority of these objectives are showing as green, which demonstrates the great work that we did last year. Just to perhaps highlight some of those where there is an amber update. And we've seen some challenges. I think the first of those relates to the implementation of the community integrator. And I think it's fair to say the implementation of some of the contracts that have transferred or are transferring as part of that has been slower than we would have liked. There's lots of reasons for this. It's tied up in the work with the ICB to establish the Care Collaborative Committee. But work is in train. A number of those contracts are planned to transfer to us at the end of Q1. We obviously have a community integrator report, a community integrator update in the IPR, and we also now have a good programme for our lead provider work established, which we will report to a future board. We've talked about workforce indicators earlier in the agenda. Excellent work on recruitment and improving turnover rates, for example, but sickness remains high. And is a concern. So there's some ambers there around that. And we've also mentioned the work that we've done in response to the CQC inspection, and I think the amber there reflects that work. So those are the key points I wanted to draw out. But by and large, really good progress on our objectives for last year.
Thank you, Adam, and thank you for your part in the leadership of all of that. Any questions or perspectives on Adam's report? Okay, so Sophie, if you're able to, we're on to the trust strategy review. Sophie?
Thank you. So this paper just sets out a bit of a position statement ahead of the 10-year plan landing. So it talks about the things we have achieved within our big moves, but also being quite honest, I think, about where some of those challenges have been and where we haven't been able to get traction or progress as we might have set out at the start. I think this is an opportunity for us to do a whole organisation engagement when that 10-year plan lands, so we rethink and reset our strategy if necessary. That being said, I do believe it will be aligned and some of the big moves that we've already got. But understanding the challenges and the focus for the next few years will help us have a really robust plan for the organisation and link into objectives moving forward. So it's a position statement really a couple of years into the strategy that we set.
Super, thank you. Sophie, any questions or perspectives to Sophie on the strategy review? Just a reflection, and if I can ask you to have a think about it with Elva and with Fiona and Bhaskar, I worry that over the next few years, I worry that it's happened partially already, but I worry about the next few years, that we will lose a lot of head knowledge as our very experienced staff come to retire. And we tend to always look at things on a numbers basis. how many nurses we have. But we all know, just in our experience of life, that the older you get and you've done the same thing time and time again, the more efficient you get and the more knowledgeable you get. Someone once said to me, I never see a doctor who's under 40 because under 40 they don't have enough experience. That was a genuine patient comment. So I'd like to just find a way of us having a better understanding that when we lose our staff, we find ways of retaining head knowledge in the flexible working arena. I hope that makes sense. Fiona put her hand up, so maybe it didn't make sense. Fiona?
No, I was going to agree with you. I think it makes absolute sense, Russell. I think I was just reading in terms of those challenges in Sophie's report around that flexible employer, and particularly it just grates against the target of reducing bank when a lot of our flexible staff actually want a bank contract because that gives them flexibility, and then the target is to stop all bank use or reduce it significantly. It's not making sense to me in terms of that direction at the moment.
If it makes you feel any better, it makes no sense to me either. And for me, you know, why is SWFT the most effectively the most productive trust, you know, almost in the country? It's because of the people. So we need to be really careful when we lose the experienced people. It's not rocket science, otherwise you just trend to the average. We need to look after our most experienced, most knowledgeable people. Pascal, then I'll move us on.
Yeah, fully in agreement. And in fact, I think we are a good example of that because we already have robust retire and return flexible policies. And I've just had an email of a nearly 70-year-old orthopedic surgeon who has single-handedly contributed to 800 hips as part of our vanguard just now. And we've had another retiring consultant who has negotiated a teaching-only contract because he's getting to the stage of. So I think we already are ahead on this. But I agree with you that this is a no-brainer that our most skilled and trusted and experienced, as you put it, very polishedly, workforce is best utilized for our mutual gains. And I think the framework is existing and can be exploited even more. Yeah,
I'd just like that to come out a bit more in this. And so it's sort of top of mind. Leave it with your team. Thank you very much. Happy to move on to the important but not always exciting issue of the summary of ratified policies. Adam?
Yes, I'll take it as one policy ratified this month, which was an update to an existing document.
Thank you. The Patient Healthcare Records Policy. Any questions or perspectives on that? Okay, thank you. Then we're on to summary reports for noting the Health and Wellbeing 6 monthly report. Elva, anything you particularly like to pull out on this?
I'll just take the report as read. I think the only thing really to point out is just around the occupational health, and that we are doing a review of that. That should be hopefully ready for updating in the next few weeks.
Yeah. Trust your instinct on that, Elva. You, with the greatest respect, but you'll understand what I mean. You've been around enough to know what needs to be done. So let's make a recommendation of what needs to be done rather than what's politic to be done. Occy health is absolutely what we need to do a better job for those who are sick and to prevent sickness. Questions and perspectives to Elva? Ollie?
Yeah, just want to say, I think it's a really great report. There's a lot of ambition to improve. There's a lot of schemes going on concurrently, and there's a lot of ambition to improve the health and well-being for the staff at SWFT. And I think it should be of particular interest to the whole board because we've got that 5% sickness rate that we want to bring down to 3%, and there's a lot of the answers are in this paper.
No, well said. Thank you, Ollie. Colleagues, happy to move on? Okay, we'll move on then to the summary of safeguarding children and young people and vulnerable adults annual report. Fiona?
Yeah, this is a very succinct summary. If you don't sit at clinical governance, you may not have seen the full annual report on safeguarding, which I'm very happy to share with any board members, because there is a much more detailed report. But basically, the assurance is that we have policies, procedures, we have partnership working, we have audits, we have training, all relating to safeguarding, and they all fulfil our statutory duty related to adults and children safeguarding. And there is a more detailed report that I can share.
Super, thank you very much, Fiona. Any questions or perspectives to Fiona on that? I thought the idea of the fidget box, which came out of Charles's presentation this morning, was a really interesting one, which we'll take forward. The Patient Forum biannual report, Chris Thornton, who chairs the Patient Forum, I know is away, so Fiona's going to take this. But before you do, Fiona, I just want to thank people like Michael Piper and others who do such a great job on the Patient Forum. It is such an important area of our volunteering work. So, Fiona, anything you'd like to pull out in particular of Chris's report?
No, it was just really to thank them. They're a small but mighty team of volunteers that really help our patient experience, work independently and most of in their work as a critical friend to us and the board, and I think they do a great work. Thank you.
Agreed. Thank you very much to them and to you. Any questions to Fiona on that? Okay, then we're on to the updated Register of Directors and Register of Directors' Interest. Sarah, anything you want to particularly highlight on this?
Just to note that both registers have been updated to reflect the changes to Glenn and Adam's roles and also the return of Fiona. And just to note that Oliver Coppler's earlier declaration has already been captured on the register. Thank you.
Okay, super. Thank you. Any questions or perspectives on this? Okay, I'd just like, and I did have a shout out, I think, at the April board to Ellie Ward for standing in for Fiona. Big boots to fill, and I know she worked very hard to try and fill them. So, Ellie, thank you very much. Board committee minutes then for the 12th of February on the audit committee. Robert, anything you'd like to add to this?
Nothing to add, Chair.
Any questions or perspectives on those minutes, please? Okay, can't see a digital hand raised. And then the clinical governance of the March and April meetings. David, anything you'd like to add to these?
No, nothing to add from me.
Any questions from colleagues on those? So, board colleagues, I think we're therefore on to any other business. Any other business? Board colleagues, please raise a digital hand. Can't see any digital hands. So have we had any questions from members of the public, Sarah?
We haven't, no.
Okay, we've got some members of the public with us and we're a few minutes ahead. Would any members of the public like to ask a question now? Please raise a digital hand. Okay, I can't see any digital hands being raised. So just to thank members of the public for joining us. Thank executive directors for their hard work and behind the scenes work of the non-executive directors. Our next meeting is on I think it's the 2nd of July is what I want to say. Sarah, thank you. And look forward to seeing you then. Take care, everyone. For board colleagues, I suggest we get back together again in 15 minutes for the confidential board. So we'll get together again at 3:15. Take care. Bye-bye.